That funding is to roll out pediatric formulations of second-line drugs.
Dr.
So
Furin, hi, it's Dr. Clapholtz here. Good morning. Perhaps if you close out and then reopen your presentation, you'd be able to advance your slides.
I can't do anything, unfortunately, right now. Once this annotation came on, like I can't do my, I'm so sorry. Ah, there we go. Thank you. Thank you.
Okay.
Let's try this again. My apologies, everyone.
Dr.
All,
Furin, not to interrupt, this is Lisa Devers, who helps coordinate it. Are you able to share your video so we can see you?
yes, I can put my video on. I can do everything now that the annotation went away. So thank you so much. I'm
Okay,
not sure,
great,
these applications have so
great.
many things. And so I'm always learning something new. So my apologies. We did practice yesterday. Anyhow, just thank you so much to you all for this opportunity. I do want to put the CME code up here because it's an important thing. So the CME code is 19123 for those of you who need it, and you should definitely get your CME for attending the grand rounds. So this morning, in the brief time we have together, I want to talk a little bit about some updated epidemiologic, clinical trial, and policy developments in tuberculosis. But I really want to examine these through the lens of something called person-centered care. And the reason I want to examine these updates through this lens is I think it really embodies the principles of humanistic medicine that Dr. McDonald embraced. And I hope that by the end of this talk, we can not only come to a shared understanding of where we are in terms of the global tuberculosis pandemic, but really to explore how TB care, as we've constructed it, can be radically transformed. And again, I want to be mindful of honoring the legacy of Dr. Reynard McDonald. I didn't know Dr. McDonald personally, although I'm sure many of you did. But from what I understand, this man was a dedicated TB warrior, and he was really committed to addressing the grave inequities in TB care that are faced by people in the United States. We're a low burden country, but people with TB face enormous, enormous challenges in the US. And he was well known not only for being a compassionate provider, but also for being a rigorous academic scholar. And he really brought the principles of humanistic medicine into his daily interactions with patients, with students, with peers. And so I want to explore TB today in 2024 through this lens and be mindful of Dr. McDonald and what he might have to say about TB today. And to do that, I think it's important. We use these terms all the time, humanistic medicine, person-centered care, but what do they really mean? And humanistic medicine is really defined by a number of practices. It means we strive for integrity and excellence in the care that we provide, but also for collaboration, not just with our colleagues and our students, but with the people who are coming to us to receive care and compassion. It's driven by altruism, but also a lot of respect and a respect for the resilience that people face when they're dealing with an illness. Empathy is at the core and a commitment to service. So these are the kinds of things I'm thinking about as a tuberculosis provider, and I know that Dr. McDonald brought into his practice. So tuberculosis care has really been driven since the 1970s by public health approaches. And public health approaches can be great. Public health brings a lot to the table, I think, as all of us saw during COVID. But a lot of times, public health approaches have had the unintended consequence of sort of erasing the individual. We tell ourselves we're operating from a point of the greater good for the population, but we lose the person who's sick or who needs care or who has the public health problem that we're working on. And so there's been a recent move in the field of tuberculosis to provide what's called patient or person-centered care. But unfortunately, the field really is using the language here without any clear definition of what this means. And there's some concerns that human rights advocates have and many care providers in TB have that the language of person-centeredness or patient-centeredness has been co-opted without any actual changes in practice. So we're still very rooted in this, population-based public health approach. And humanistic medicine is really one component, I think, of person-centered care that's missing from tuberculosis. But we need radical changes in how we approach tuberculosis. When I was a medical student a long time ago, I didn't really think about tuberculosis. I sort of thought it was a disease of the past. And in fact, when I was explaining to my parents that I was going to be a tuberculosis doctor, my mother said, "Oh, you didn't do well in school, huh? Because why would you treat a disease that nobody gets?" And so I had to explain to my family that TB affects 10 million people a year. And when I started medical school, back in 1995, it was 10 million people. And today it is still 10 million people a year who become newly sick with tuberculosis. And more than 1 million die of this preventable and treatable disease. And there's something fundamentally wrong with that in this day and age. Back in 2018, there was a very high-level meeting held by the United Nations that set out some goals on where we needed to be in tackling the tuberculosis pandemic. And these goals were about reducing catastrophic costs and suffering, reducing incidence, reducing death, providing a certain amount of TB preventive therapy. And in 2023, the United Nations met again to review the indicators, and unfortunately, none of them were met. Except for one. And while there was a lot of talk about this being due to COVID, the truth of the matter is none of these indicators were on track to being met, which is somewhat puzzling for a disease that's treatable and preventable, but I think is somewhat driven by the fact that we haven't embraced practices of person-centeredness. And I looked to the only goal that was met in the UN high-level meeting, which was the provision of tuberculosis preventive therapy to people who were living with HIV. A goal was set, and that goal was actually exceeded. And I think that's because this was an achievement of HIV programs. And HIV programs have always been a bit more humanistic and a bit more person-centered than TB programs. And unfortunately, in the TB space, we continue to seek out new drugs and new regimens and things that are shorter, and we hope to science our way out of this global pandemic. But I would suggest to you, science is not going to be enough, and that a different approach is needed. So as we go through this morning, I think there are 6 important questions for consideration when we ask, is TB care humanistic? And the first is, do we treat people with TB as individuals? And do we consider their preferences and needs? The second is, do we consider and address other pressing health and social concerns that people with TB face? The third is, do we consider people with TB as important parts of their families and their communities? The fourth question is, do we practice equity for the most vulnerable people with TB? The fifth is, do we establish and foster trusting partnerships between healthcare services and people with TB? And then the last is, do we operate from a place of compassion or fear when it comes to our interactions with people with TB? And I'm going to present some of the new exciting science and data that's been emerging in the TB space in the last decade this morning. But I think these humanistic questions are important for us to consider. So the first is, do we really treat people with TB as individuals and consider their preferences and needs? And I think the answer to that question is a resounding no. There were 2 opinion pieces that came out last year in the journal Public Health Action that were authored by people who had survived TB or were themselves impacted by TB, where they talked about the fact that a one-size-fits-all approach, which we love in public health, we think it makes it simple and error-free, that this one-size-fits-all doesn't really work when it comes to tackling TB. And they really laid out an agenda about choices and preferences and taking people who are living with the disease views and needs into account. And I'd like to talk through some of the more recent clinical trials showing that science is still really focused on this one-size-fits-all approach. So I want to talk about a field that I've been working in for almost 30 years now, and that's in drug-resistant tuberculosis. And drug-resistant tuberculosis is a serious global problem. It affects about 500,000 people every single year who are newly sick with drug-resistant forms of TB. And this has always sort of been a great specter hanging over our heads in the TB space, and really in any space where we're treating infections where people worry about resistance. And unfortunately for people who had drug-resistant TB, up until very recently, until 2016, if you were lucky enough to get diagnosed and offered treatment for drug-resistant TB, the standard of care regimen lasted for 18 to 24 months. It consisted of between 5 and 9 medications, including one that was a daily injection that was given for at least 6 months. So people with drug-resistant TB globally had to have a shot in the gluteal area every day for 6 months, and it was a painful injection. It led to hearing loss, permanent hearing loss, in as many as 60% of people who are receiving it. And this horrible 18 to 24-month regimen cured about 60% of people who were living with the disease. So it was really tough. And so there's been a lot of investment over the last decade in looking for shorter, safer regimens for drug-resistant TB in particular. And the field of TB drug development really stagnated for almost 50 years. So the first new drug that was developed specifically to fight tuberculosis was a medication called bedaquiline that was granted conditional approval by the US Food and Drug Administration in 2013. So after almost 50 years with no new drugs. And then a second new drug quickly followed there called delaminid. And in the drug-resistant TB space, we got very good at repurposing drugs that were discovered or intended for other diseases. And so linezolid, a drug that's used to treat serious resistant gram-positive infections, was also found to be effective against tuberculosis. And sort of with these two new drugs and the repurposed drug linezolid, there were a number of opportunities to look at new regimens for treating drug-resistant TB. And people were really focused on an all-oral regimen to avoid these sort of dangerous injectable agents, and a regimen that could be shorter, right? 24 months, 18 to 24 months is a long time. So there was sort of these trials that were conceived of more than a decade ago that were now coming to fruition. And I want to talk through some of those. So the one that I think most people in the US might be aware of if you're operating in the TB space is a regimen called the BPALM regimen. We love our abbreviations in medicine. And BPALM stands for bedaquiline, pratomanid, a third new drug, linezolid, and moxifloxacin. So this was sort of a revolutionary regimen that lasts for 6 months. It contains those 4 drugs. And in the trial that was actually done by Médecins Sans Frontières in collaboration with a number of academic institutions, they tested this 6-month regimen against the locally accepted standard of care. So it was a randomized control trial. It was done at multiple centers, but primarily in Uzbekistan. And the trial actually was stopped early by the data monitoring committee because the shorter regimen, the 6-month BPALM regimen, showed increased efficacy compared to the standard of care. And the Data Safety Monitoring Committee really took the unprecedented step of stopping the trial early because of efficacy of the experimental regimen. So this regimen was shown to have improved efficacy and safety compared to the standard of care. And later data from the long-term outcomes did show there was some resistance development to bedaquiline among the people in the trial who had drug-resistant TB that was also fluoroquinolone resistant. But this was a really interesting trial, and I want to talk through it a little more. The unfavorable outcome was something that was a composite outcome, which we do a lot in TB trials. TB trials take a long time to do, right? If you think about it, if your standard of care regimen lasts for 18 to 24 months, and you have to have a 12 to 24 month follow-up period, every person who's enrolled in the study is potentially in that study for 4 to 5 years, right? And it takes a long time to recruit people. And so trial investigators have come up with a number of ways to try to shorten the trial duration. And one is by using this composite outcome. So in the BPALM trial, the unfavorable outcome was a composite outcome of death, treatment failure, treatment discontinuation, which was counted as the discontinuation of 2 or more medications in the standard of care regimen, or 1 or more medication in the experimental regimen, loss to follow-up or recurrence of tuberculosis. And then the safety outcomes that they looked at in the trial were at least 1 serious adverse event or an adverse event of grade 3 or higher at 72 and 108 weeks post-randomization. So this was the randomization scheme for the BPALM trial, or what's called the Practical trial. They were initially looking at testing a number of regimens, and it was determined that these 3 different bedaquiline-containing regimens would be compared to standard of care, and that they would look at that after 8 weeks. And that after 8 weeks, they had sort of set a minimal bar that the regimens had to meet in terms of safety and efficacy. And the trial investigators decided they would only carry forward the arms that met these minimum endpoints. So the arm that they carried forward was the BPALM arm. And so they randomized people to receive that or the locally accepted standard of care. So this was not a placebo-controlled trial. It was an open label trial. And patients who got the BPALM regimen, their end of treatment was at 24 weeks, and the standard of care regimen lasted for 18 to 24 months. And the primary analyses were done at 72 weeks post-randomization so that people could be evaluated at the same time. So, and again, what they found, and that led the Data Safety Committee to stopping the trial, is that there was a significantly higher rate of unfavorable outcomes in the standard of care arm compared with the experimental arm. And that the Safety Monitoring Committee looked at this and thought, given this Kaplan-Meier plot, that it was futile to continue enrolling in the study, and that these results were quite impressive. And then this is in the per protocol analysis. So this was the modified intention to treat analysis, but the differences were sustained in the per protocol analysis, which looks at people who actually got treatment as they were supposed to. So people were very excited by this because for the first time we had strong clinical trial evidence to recommend an all-oral shorter regimen for drug-resistant TB. And this is a busy slide, I apologize, but it just shows actually that the safety of the bedaquiline, pertomanid, linezolid, moxifloxacin regimen was better than the standard of care. So this study generated a lot of enthusiasm, and in fact, in the United States, if you have drug-resistant TB, you now get that BPALM regimen. And so people were very excited about this. But there were a number of other trials that have been done recently to look at other all oral shorter regimens. And again, these trials were conceived of more than a decade ago. And in fact, the NTB trial, which I'm going to talk about next, and the Practical or the BPALM trial were started around the same time. It's just these trials take forever to finish. So the NTB trial was a multi-centered study, and they actually had a very novel trial design for drug-resistant TB. They didn't just want to compare one regimen to the locally accepted standard of care, but they wanted to compare 5 different regimens to identify as many regimens as possible that were non-inferior to the locally accepted standard of care. And these regimens that they looked at all had combinations of bedaquiline, delamanid, linezolid, fluoroquinolone, and or pyrazinamide. So it was a really interesting trial. It was open label, it was non-inferior, it was a phase 3 trial, and they compared each of these 5 experimental regimens to the locally accepted standard of care in terms of both efficacy and safety. But they did it in a way that used Bayesian randomization, and I'm not a statistician, so I apologize to those of you who are if I explain this wrong. But in Bayesian randomization, what you can do is randomize people to one of the 6 trial arms. And then at certain endpoints, an analysis can be done just by the statisticians, and a trial arm that is not performing well can be dropped from the randomization, and trial arms that are doing well can be enriched for the randomization. And this is done to sort of make the trial easier to do and to compare multiple regimens. And they sort of borrowed this from cancer clinical trials. And so this was a not only novel drugs and novel regimens, but a novel trial design. And again, the goal was to detect as many non-inferior regimens as possible. It wasn't saying what's the best regimen, and it wasn't comparing the 5 experimental regimens to each other, right? And I think that's a key point. It was just saying we have a standard of care that's locally accepted, and we want to compare each of these 5 regimens to the standard of care regimen to see which 5 of the 5 might meet this non-inferiority threshold. So this is the trial design, and you can see the regimens there. The first one these were all 9-month regimens. The first was a regimen of bedaquiline, linezolid, moxifloxacin, and pyrazinamide. The second was a 9-month regimen of bedaquiline, linezolid, clofazimine, levofloxacin, and pyrazinamide. The third was a 9-month regimen of bedaquiline, delamanid, linezolid, levofloxacin, and pyrazinamide. The fourth was a 9-month regimen of delamanid, linezolid, clofazimine, levofloxacin, and pyrazinamide. And the fifth was a 9-month regimen of delamanid, clofazimine, moxifloxacin, and pyrazinamide. And these all lasted 9 months, and then they were compared with the locally accepted standard of care. And the primary efficacy endpoints were assessed at 73 weeks and the safety throughout. So what they found, and I'm going through a lot of complicated trials very quickly, I apologize for that, but they found actually that the first 3 regimens met the non-inferiority threshold compared to the locally accepted standard of care. The 4th regimen did not, and the 5th regimen only met the non-inferiority threshold in the per protocol analysis. So there's very robust evidence for the first 3 regimens that they can be all oral shorter regimens for drug-resistant TB. And then there's weaker evidence for the 5th regimen. So the efficacy was that there are now 3 additional robust regimens that are non-inferior. And the key here, right, they weren't just trying to find one regimen. They weren't just trying to find a one-size-fits-all regimen. They were saying you have these options, right? And so all of a sudden, this concept of person-centeredness comes in, right? Because we now have options for treating drug-resistant TB. These drugs can be given to all age groups. They've been used in pregnant people. The WHO recommends them all. And so this is a wonderful thing if you're a patient. Programs are not so excited about this because they like the one size fits all. But the NTB trial, because they continued to the end of the trial, they were really able to make a lot stronger statements about the efficacy and safety of these regimens and to look in subpopulations. So the results were consistent across a number of comorbidities, including HIV, diabetes, and hepatitis, and in people who had severe forms of drug-resistant TB. They did find the less robust evidence for this regimen consisting of delamanid, moxifloxacin, clofazimine, and pyrazinamide, and suggest that this is a good option for patients who can't take drugs like bedaquiline or linezolid. Yeah, it's a very strong evidence base, which is now going to be reviewed by the World Health Organization. They also found low mortality, but that the safety of the standard of care regimen was worse than any of the experimental regimens. So I'm going to go through that quickly. But what we now have on the table in front of us are multiple options for treating patients with drug-resistant TB. There are a number of other studies that are being done or coming out now, including several trials from single country studies in South Korea, in South Africa, in India. The problem that we're running into as we make recommendations for patients and for programs and for countries is none of these compared the shorter all oral regimens to each other, right? They were all compared to this locally accepted standard of care, which is really no longer the standard of care. So programs and policymakers are really fretting. They're like, which one do we recommend? They tend to be recommending the cheapest regimen, which we often see. But one alarming thing about all of these trials is that people with drug-resistant TB were never asked about their preferences. There were no acceptability studies done, and that we really don't know what people with TB might prefer. And this is a historical legacy, I think, of not really caring about what people with TB prefer, because our public health and our non-humanistic approach to TB has been they should just take what we give them. Doesn't matter what they want. It matters what we want and how to convince them to do what we want. And so even in this exciting time where we have a lot of new trials, I think we're dropping the ball in terms of understanding people with TB's preferences and needs. And people are really focused on shorter is better. I hear this all the time at TB meetings, at clinical trials discussions, that we can just shorten our way out of TB, right? And that might be true if we could get TB treatment down to, a week or 2 weeks. Although I would suggest as an infectious diseases provider that even antibiotic regimens that I give to patients lasting a week to 2 weeks can be challenging for them to complete. But we're really just focused on shortening. There's a big push to go back to a universal regimen that everyone can get the same treatment, whether they have drug susceptible or drug resistant TB, to not doing drug resistance testing. And acceptability studies are not routinely built in or funded. And we really see this in the drug susceptible TB space now as well. And I just want to briefly talk about a trial that was called the Truncate TB trial, which was a proof of concept study that looked at a number of 8-week regimens for drug susceptible tuberculosis. And this was published last year in the New England Journal of Medicine. And Truncate TB, what they did is they took the standard of care regimen for drug susceptible TB, which is a 24-week regimen of INH, rifampin, pyrazinamide, and ethambutol, or what people in the US called RIPE. And they tried comparing that with a number of experimental regimens given for 8 weeks that included linezolid or bedaquiline, or linezolid and bedaquiline, just to see would 8 weeks be possible. And in this proof of concept study, what they found is that an 8-week regimen that contained both bedaquiline and linezolid theoretically in 8 weeks met the standard for non-inferiority compared with the standard of care regimen. And they're planning to pursue this further in other trials. I think some of the challenges with bedaquiline and linezolid are these are drugs that have side effects associated with them. And so, you may be able to shorten the treatment, but the question is, is the toxicity going to be tolerable, and will this be acceptable? So keep your eyes in the future on the Truncate trial as they move this bedaquiline and linezolid containing regimen into further phases of analysis. And again, this is just a study, a slide from Truncate showing the unfavorable outcomes in the 24-week standard of care were 3.9%. They presented 8 weeks of high-dose rifampin and linezolid, where the 8-week outcomes were, unfavorable outcomes were 25%, which is not non-inferior. But the bedaquiline linezolid arm, the outcomes that were unfavorable were 13.8%, which did meet the non-inferiority thresholds that they set. So more will be revealed, but shorter may be better in some ways, but regimen duration is not the only thing that impacts acceptability. And I think we have to build in more understanding of what people with TB need and want in their treatment regimens, not just what the scientists want. So moving on to the next question is, do we consider and address other pressing health and social concerns people with TB face? I've worked in the TB space for almost 30 years, and I will tell you that most of the people that I work with who are diagnosed with the disease will tell me this is not their first problem, this is not their only problem, and in fact, it's not usually their worst problem. So people with TB face a number of issues with housing and food and migration and a number of other difficult issues. And I think, unfortunately, in the TB space, we're very focused on the drugs and the regimens, but we're far less willing to help out and address some of these other concerns. They're not really our purview or our problem. We see them. And I want to talk a little bit about a really interesting study that was done recently in India, looking at TB prevention. So as many of you know, we have something called TPT, or TB preventive therapy, where people who've been infected with the TB bacillus but who are not yet sick can be offered treatment with 1 or 2 drugs for a short period of time, and we call this TB preventive therapy. We have a number of new regimens that are out now, including a 3-month regimen of isoniazid and rifapentine that's given once a week. a 1-month regimen of daily isoniazid and rifapentine. And then recently, there have been studies showing the effectiveness of levofloxacin for the prevention of drug-resistant TB. Everybody's really focused on rolling these out and these drugs, but there was a study done in India called the Rations trial, and this was done in Jharkhand, India. This was a cluster randomized trial, and the trial assessed nutritional supplementation for households in which a person was newly diagnosed with TB. So in a cluster randomized trial design, everybody gets the intervention. It's just not all rolled out at the same time. So it's rolled out in a clustered way, and they can compare the intervention with the pre-intervention period. So in all the households where someone was newly diagnosed with tuberculosis, the person who was diagnosed with TB got nutritional support. But the intervention that was rolled out in these clusters was that nutritional support was provided for household contacts in the intervention. And it wasn't a lot of nutritional support. It was 750 kcal, so like 2 cups of beans with 23 grams of protein and micronutrients. So pretty minimal nutritional support. But they looked at the rate of incident TB among household contacts. And what they found was that nutritional supplementation reduced TB incidence in household members by 39 to 48%. The difference was statistically significant. It was really remarkable because this is as high as for many of the drug regimens that were out there trying to push as TB preventive therapy. And I think what the ration study showed was really the really precarious nutritional situation many people and households with TB face. And this study was published in the Lancet and highlighted in the Lancet as one of the most significant papers that they've published. But TB programs are not discussing this, right? Everyone's talking about 3-HP and 1-HP and levofloxacin, but not nutritional support. And for some reason, we feel like it's not our job to address these things, even though people living with TB struggle with them every day. So do we consider people with TB as important parts of their families and communities? And well, I think individual providers do. From a programmatic perspective, we tend not to. But when we talk about TB, we know it's an airborne disease, and most of our health interventions focus on individual risk factors, right? Are you living with HIV? You know, do you have diabetes? All these other individual risk factors. And we've really erased sort of any kind of family-centered approach, right? In TB, we have adult TB, we have pediatric TB, we don't see people in shared medical appointments. And we really try to look at the individual outside of his or her local context. But there was an interesting study that was done in Pakistan where they did active case finding for TB, not just in the households of people who were newly diagnosed, but they did it in a 50-meter radius around the household. And what they found is that when they assessed for TB, keeping confidentiality, not telling the neighbors, oh, so-and-so was diagnosed and that's why we're checking you, but kind of doing these TB campaigns in this neighborhood-based approach, they found that 20% of people in a 50-meter squared radius of someone who was newly diagnosed with TB also had TB. Right, the rates were about 20% in the households, right? And I think we forget, we try to remove people from their communities and we don't consider them as not only as individuals, but as part of a family, as part of a community that they desperately want to get back to being part of. And we have to change this. So another question is, do we practice equity for the most vulnerable people with TB? And again, I would suggest the answer to that is no. And it's not an accidental no. Right, back in the 70s when TB public health policy was being decided, the policymakers basically said, we're never going to be able to take care of everyone with TB. So let's just focus on people who are transmitting TB. Right? And they called them transmitters, which is really not person-centered at all. But in this decision making to ignore certain groups of people with TB, children were systematically left out of TB public policy, right? They're a high risk group, but they tend not to have cavitary pulmonary disease and they tend not to transmit. So this decision that was made in the interest of public health meant that children were left behind. And even today, the legacy of that is they're often the last to benefit from advances in care. So one example is we finally, after many, many years, have pediatric formulations of most of the TB drugs, but you can't get them in the United States, right? They're not registered here and nobody's gonna register them here. And this is really unfortunate. So we don't seem to provide equity. Another question is, do we establish and foster trusting partnerships between healthcare services and people with TB? And I would suggest again that the answer is a resounding no. And you only need to look at our cornerstone of TB care, which is directly observed therapy, right? DOT, it's part of TB care. You have to do it. You have to do it. And I've seen some amazing nurses who provide incredibly compassionate, directly observed therapy. For those of you who don't know, directly observed therapy is where someone watches you swallow your pills every day. And inherent in directly observed therapy is a relationship that's rooted in fundamental mistrust, right? I don't trust you're going to take your tablets. So you have to either come to the clinic every day and take them, or let me watch you over a video. And this sends a message to people who are living with TB about what we think of them, right? And while directly observed therapy can be a supportive way to check in with people to see if they're having any side effects, it primarily says to people with TB, I don't trust you. And we may watch you on video now, or some people are proposing we put little sensors in the TB tablets and make people wear a patch to see if they're actually ingesting them. But this is a relationship based on mistrust, right? It's not person-centered. And there was an interesting study done in South Africa that looked at people who were living with drug-resistant TB and HIV to assess adherence. And what the study found is people were far more adherent to their antiretroviral therapy than they were to their drug-resistant TB therapy, even though they took the TB therapy under direct observation. And some of this had to do with pill burden, and some of this had to do with side effects. But in a qualitative exploratory analysis where people were asked about this, people said, well, my HIV drugs are my responsibility, right? I know my CD4 count. I know I have to take those tablets, but my TB tablets, that's the responsibility of the doctors and nurses. They don't even trust me to take them. So the ownership, right? This partnership was really missing. And when you build a program on a fundamental building block of mistrust, there's going to be challenges. So this is sort of my last topic area and my last question, which is, do we operate from a place of compassion or fear when it comes to our interactions with people with TB? And for this, I just want to look a little bit at our infection control policies. So we all know, working in the US, ooh, you say the word TB in one of our hospitals and the army comes out of infection control, right? But most infection control measures are implemented after somebody's been diagnosed with TB, and most transmission occurs prior to the diagnosis being made. But our infection control guidelines, they're not evidence-based at all. They're based on fear, and they can actually perpetuate discrimination. And we know from some really interesting guinea pig studies that were done in South Africa, where people with TB were put on a ward where all the air was filtered up to guinea pigs, and then they looked to see if the guinea pigs got infected, that transmission is almost halted after 24 to 48 hours of effective therapy. And there are reasons for this, likely due to DNA damage to the mycobacteria. But we have evidence that shows 24 to 48 hours of effective therapy is enough to render TB non-infectious. So why do we have these 2-week rules? Why do we keep children out of school? Why do we keep people out of work? And it suggests to me that we're operating from a place of fear rather than compassion. So I'm going to end here so that we have time for questions and discussions. And I know I flew through a lot of information there. There's a lot to do in TB. And for those of you who are young doctors who are interested, it's a great field to work in. It's a great field to be a care provider in. It's a great field to do research in. But I think I've painted a picture that, while exciting in terms of some of the developments, is really lacking in terms of a humanistic approach. And I think, you know, Dr. McDonald would probably have a lot to say. But so what do we do? How do we make TB care more humanistic? And I want to close by sharing images of 2 of my colleagues and friends, both of whom are survivors of drug-resistant TB. And the reason I want to share Goodman and Boosie's photos with you is that what I've learned in my practice and over the years is that the best way I can make sure the care that I'm providing is humanistic is I ask them, right? I ask them, I ask people who have survived this disease, who are living with the disease, what do we do? And I have to say, in 30 years, their answers haven't changed that much, right? They want to be treated as people, right? They want to be engaged as partners, They want people to understand what their lives were like before they became sick with TB and what their lives are like now that they're trying to negotiate not just TB, but a number of other issues. Right? They're incredibly insightful. They're incredibly brave and thoughtful, and they want to be engaged as partners in this journey. Right? And not as people who are getting the benefits of a public health approach where one size should fit all, right? But as true partners as we move forward. Right? I mean, we can have this lecture 10 years from now, 30 years from now, and if we keep trying a one size fits all approach that takes the person out of TB, like it may be easier, it may look cost effective. I don't know that it actually is based on where we are in TB, but we have to ask ourselves what's going on when a disease that's curable and a disease that's preventable kills more than 1 million people every single year. And I think the missing ingredient in TB is that we don't take a humanistic approach. And so I hope we'll be inspired by Dr. McDonald and his legacy, and to really think that as exciting as the science is, we really have a long way to go in terms of bringing the person into the center, into the focus with the care we provide for TB. So I'll stop there. My email is here. It's jenniferfurin@gmail.com. I love to talk about tuberculosis. I could go on for hours. My husband will tell you, but I'm happy to answer any questions. I put the CME code back up there again, just so that you all have that. And I'll stop talking. So thank you so much for your time.
Dr. Furin, thank you so much. Dr. Clapwell's here, Chair of the Department of Medicine. This is really a wonderful lecture, and provocative and informative, sensitive, and I think really tremendous for all of us to hear, from medical students all the way up to senior faculty. So I really appreciate that. I want to note, that the differentiation between patient-centered care and sometimes public health, and how we should be thinking about that. I also want to acknowledge your call out of Dr. McDonald, and for those of us that did know him, I think your definition of what humanistic medicine is that you started out with, I think would fit him to a T. And so I want to acknowledge that as well. He was a humanist, and he really did provide sensitive and humanistic care to patients, and we were all proud to have him here as a faculty member. Learned a great deal from him. With that, I really do want to open it up for questions, and I want to encourage people to either raise their hand or put something in the chat, and we'll go through that. And while we're waiting for that and for some questions and comments, lots of things that you talked about. Let me just pick up on the nutritional paper you showed from India, giving some supplementation and reducing the seems like the transmission or the infectivity of TB, as TB does, even in the U.S., affect folks who have real challenge in the issues of social determinants of health, food deserts being one of them. Do you see any opportunity here also in the U.S. in certain patient populations? Do you think that's something that should be studied? Do we know anything about that, or not? What do you think about that?
Yeah, I think absolutely the social determinants are the most important, and they'll vary, right, depending on the setting. Jharkhand, India is very poor. And it's an area that's plagued by food insecurity. But as you mentioned, right, people in the US may be getting sufficient calories, but they're not getting good calories, and food deserts are certainly one issue. We tend to want to look at giving people vitamins. Like there's a lot of studies on vitamin D supplementation or vitamin A supplementation. But I really do think that providing vitamins in the form of food has multiple collateral benefits. So the first is it acknowledges that the family or the household might be struggling, and there's no downside, right? There's no downside to helping people with better nutrition, although some people would say it fosters dependency and we can't be doing that. I think that when I've talked with patients where we provide food supplementation, they really feel grateful. They say, these 6 months have been really hard for my family. I can't go to work. We're dealing with a lot of other issues. So what those food packages look like will probably differ depending on the setting. And the other thing I didn't say is, TB programs don't have to do this alone, right? It's not like the TB providers have to provide the nutritional support. Right? They have to acknowledge that nutritional support is needed, and they have to work with partners and colleagues who are experts in nutrition and nutritional support in the various areas. And, you know, it's often a question. I was trained by Paul Farmer, and he was my mentor, and he would say, why is it okay to keep giving people vitamins but not give them food? What's that about? Right? What's that about? And, you know, in the US, the social determinants are really heavy because it's a low burden country, right? So we see a lot of issues with immigration and people feeling discriminated against. And I think we have to understand what those are and provide them. And a pill isn't going to answer all our questions, although we like to give pills better than we like to give food. So.
Yeah, thank you. Thanks very much. Lots of comments that really are also acknowledging your talk today and how much it's impacted all of us who've been listening to you. So just please know that. Dr. Ladizabal, I think you have your hand up.
Yes, hi.
Hi, Al.
Thanks so much for your wonderful lecture, and we really appreciate the message that you just shared with us. Really, not just for TB providers, it's really for all physicians to kind of embrace a more humanistic approach for their patients. The annual TB surveillance was supposed to come out today, but it was delayed by about a week, I think. They're probably trying to tidy up the numbers, make sure they're correct. But for all intents and purposes, I think the New York, New Jersey region is likely going to see anywhere from a 10 to 30% increase in the incidence for 23. So that really brings us back and reminds us to sort of keep up the work and remain vigilant, and that, you know, TB anywhere is TB everywhere. It's a kind of an old saying that, you know, you don't just walk away from it because it's still around. I like the progress we've made in the treatment of drug-resistant TB over the past 5 years or so. Quite encouraging. But again, as you touched on earlier, there are pockets that we still leave behind, kids and pregnant mothers.
Oh, thanks.
Yeah,
Well, he has just,
what's the progress with
he
regard
just
to
has a
kind of
few items.
including them in
Fine, I'm really fine.
research,
Let
pushing
him go
for
first.
that?
I'll go after him.
Well, thank you so much for your comments. Yeah, the issue of including children and pregnant people, pregnant women in studies is an important one, right? And it's again acknowledging where, you know, an altruistic impulse may have gone awry, right? So children and pregnant people, pregnant women were traditionally excluded from studies, right? Because we didn't want them to face the toxicity of new drugs and new regimens as they came out until we were sure that you know, they weren't going to cause notable problems for them, right? But the issue is then that in a field like drug-resistant TB, where the standard of care is so bad, is so awful, what it means is that children, pregnant people are the last to benefit from the advances, right? I can't tell you, you know, so I was working in drug-resistant TB when bedaquiline came out, and we were very excited about this new drug because it had the potential to eliminate the injectable agent, right? But it wasn't tested or used in children. And so when the WHO recommended bedaquiline, they said, we can't recommend this for children. And so there were countries, like I remember in India, their guidelines specifically said children should preferentially receive an injectable agent. And this was very shocking, you know, because children should probably have been the first ones who shouldn't have. And so these perverse paradigms of protection that end up hurting people, and we have to be able to acknowledge those things and find a way to include people sooner. And so there has been a great movement to include children and pregnant people in clinical trials as soon as the phase 2 studies show the safety is reasonable. But, you know, the 3-HP regimen, this preventive therapy regimen, right, that was really exciting. 12 weeks of once a week of isoniazid and rifapentine. That trial was done in 2011, right? The New England Journal of Medicine paper came out, and it is only this year in 2024 that we have data on kids, right? And so what it taught me, what all of this teaches me, is that even when the best trials are done, there are still going to be groups of people that need our advocacy. And so in the TB space, it's not enough to just be a clinician. I'm a clinician. I love taking care of patients, but I very quickly learned I had to be an advocate too. And so advocating for these groups that are left behind. And there will always, TB is a disease that capitalizes on the groups that are left behind. So embracing some of that advocacy role, I think, is something we all have to do as well.
Yeah, thanks, Dr. Furin. Dr. Elner?
Hi, Jennifer. We haven't talked in 20 years, but it's good to see where you're at in your career. And thank you for this lecture. It's perfect. Dr. McDonald would have loved it. I also wanted to comment that he was revered medical attending, and that counts. He wasn't just a TB expert that we all listen to. I learned last week that there's increasing bedaquiline resistance in South Africa due to mutations in an efflux pump, which is concerning. And it reminds me that I've always felt that we need a vaccine, an effective vaccine, and there are some vaccines which look effective. But of course, we found recently in the US concerns about vaccination. In your work, do you get any sense that a vaccine for TB, if effective, would have reasonable uptake, particularly if required adult vaccination? Thank you.
Yeah, thanks, Dr. Elner. It's great to see you again, too. And thanks for coming today. Yeah, this concern about resistance to drugs is always going to be with us. I always tell my fellows on the ID consult service that the only way to not select for resistance to a drug is to never use a drug, right? It happens, it's evolution, it's part of what we do. And we might be able to decrease it if we provided more person-centered care to people. But yes, vaccines are essential in the fight against TB. And I think uptake would be good. BCG vaccination uptake is nearly universal in the settings where it's offered, and it does protect children from severe and disseminated forms of disease. There were some ruptures when everyone tried to steal the BCG to use it against COVID, but for the most part, uptake is quite high. I think it would depend on how people, how the vaccine was discussed with people, what sort of choices they were given about it. And I think we'd have to do our social science homework. We learned a lot about vaccine hesitancy during COVID. But the complex interplay between tuberculosis and the immune system is one that continues to baffle and amaze me. Too much immune system is a problem, not enough is a problem. People who have TB once are more likely to get it a second time because their immune system probably learns how to deal with it wrong. But I remain hopeful in the setting of, we had a COVID vaccine in under a year. But I do think, again, it will require, we're not going to science our way out of this, right? We're going to have to, at some point, engage with humans in all the messy ways that humans require engagement. And that's, I think, the only way we're going to get through it. And if I were working on vaccines, I sure would have a lot of people with TB advising me, or people who survived TB advising me. And I'm not sure that they're included in those discussions in anything other than sort of a tokenistic way.
Yep. Thank you. I totally agree.
Thanks very much. We are blessed in our institution. Really, tremendous TB researchers, Dr. Elner, obviously having led so much in this arena. So, thanks everybody for joining. I thought we've got Dr. Pachawala, who runs actually our TB treatment programs.
So thank you so much. I think Dr. McDonald, I echo that he would have loved this talk, and he asked, many of these same questions every day. I think one of the points you brought up, really, all of them are extremely important. I think the most difficult one, seeing patients with tuberculosis on a daily basis, is really the isolation, both from an emotional standpoint, but also from an economical and financial hardship point of view. As you know, the NTCA is working on some changes in the community isolation practices, and I was wondering if you have any opinion on that. Is that going far enough, or not at all? If we're bringing this up, and if we're doing the sort of the study of the topic, should we go further than sort of what's being proposed?
Yeah, infection control is always a topic that engenders spirited discussions, right? Because people say, if there's even a chance, if there's even a slight chance, we have to keep people isolated, and they don't think about it. I recently admitted a young man to my hospital. He was a 24-year-old basketball player from Sudan who was in Cleveland, who had monocular blindness because he threw a clot to his retinal artery, and because he was from the Sudan, they put him in isolation for TB. I mean, it bordered on discrimination, and we got him out after a lot of battling. But infection control in TB is fear-based. Most transmission happens prior to the diagnosis being made, right? It's not all, but as long as you can get rapid drug susceptibility testing, which we can through GeneXpert, and start people on effective therapy and help them stay on effective therapy, right? There's really, Ed Nardell's studies show that really after 24 to 48 hours, they're not infectious anymore, right? So I think the key when we talk about infection control is really how do we help people stay on therapy, and how do we help make sure that they're able to be successful in their treatment? And these in Peru, they keep them out of school for 3 months. What's that about, right? And so I think we have to acknowledge, right, that our infection control as it stands now is based on fear. What does the data show us? The data shows, within 24 to 48 hours, people are non-infectious if they're on effective therapy, and then go from there to determine what that looks like. But, it used to be like, and there should also be some harm reduction in there, right? I'm also an HIV doctor, right? Never touch another human being and you might not get HIV, but that's no way to live, right? And we looked at sort of risk stratification and risk reduction there. And I think, people who are diagnosed with TB, like their worlds fall apart. And then we tell them, don't be around anyone. I mean, in other countries where I work, they tell them don't share cups and don't share plate. I mean, it's just unbelievable when you look at some of these things that are done in the name of public health, how it ends up hurting people. I don't want TB transmission to be happening. I really don't. But most of it happens before I meet the patients, and yeah. So I think we have to look at what the data show and go from there. So thank you.
Thank you so much.
Dr. Furin, sorry, I think our time is up this morning, but on behalf of the department, I can't thank you enough for this really wonderful grand rounds this morning and discussion, and in honor of Ray McDonald. So thank you very much. I want to thank Dr. Lard Disabel, who is the director of our Global TB Institute, for sponsoring this morning's grand rounds. I want to thank everybody for participating. I want to thank everyone for their really insightful comments, and thanks again, and wish everyone a great rest of the day. Thanks so much.
Great. Thank you so much, everyone, for this honor. It was a joy to be with you this morning, and thanks for the work you do.
Thank you.
Jennifer.
Have a great rest of the day.
CME number? CME number? Question mark? Oh. hello, is there a CME number posted?